leading to collapse and is associated with some form of neuropathy. It is a progressive disease, which is a key component to highlight. Failure to recognize and offload a diabetic foot can lead to significant deformity and amputation. The Charcot foot is characterized with nonspecific inflammation and edema that can persist for weeks, even months. It can also be recognized by oftentimes painless fractures and dislocations of the joints of the foot. Charcot foot has a history that is rich with key developments in understanding its etiology and its management. I'd like to take you through a brief journey through time to understand this deformity. The history of Charcot starts with the insane asylum in the 17th century. Salvatore Hospital was originally established as a gunpowder storage facility. It was then later transformed into a hospital by King Louis that housed the elderly, the sick, and insane women. Later on, there was a special wing added for prison for insane individuals. This painting represents that period of time when prostitutes were transported into the prison within the hospital. This painting represents the open courtyard within the hospital that still exists today. Around that time period, Jean-Martin Charcot was a young physician and very observant. He did much of his early training at this hospital. He is currently considered the father of neurology. Charcot described the Romberg sign, although Romberg had previously described it. This basically indicates impaired position sense in patients with tabes dorsalis. Charcot introduced the term Romberg sign. Diabetic patients relied on visual cues to maintain their equilibrium. Patients would lose their sense of balance and fall. They closed their eyes when standing upright. Remaining steady on their feet while walking in the dark also proved to be difficult for the affected individuals. Charcot's careful attention to clinical histories revealed that patients with diabetic joints often experienced lightning pain, like a shower of electrical needles. The pain was of short duration, but recurrent throughout the day. At the same time, these pains were accompanied by loss of sensation and hyposthesia. All these preceded the arthropathy portion of the disease. The patients were showing wide-based gait, hypermetric lifting of the right leg, and if you notice in this picture, the spreading of the arms in order for him to keep his balance. Charcot brilliantly illustrated his case presentations with a wax model of a 60-year-old woman named Berthold, showing the character of ataxic affection of the joints. The wax models was accompanied by the complete skeleton of the patient and serial photographs taken at different stages of the disease. Bone and joint lesions of locomotor ataxia. These are some of the anatomic specimens that Charcot used during this presentation. He demonstrated arthropathic affections of locomotor ataxia at the 7th International Medical Congress in 1881. These specimens are currently conserved at the Neurology Museum of the same hospital. These pictures show complete destruction of the various parts of the weight-bearing portions of the skeletal system. Because of his work, Charcot was recognized with the disease name. He was the first to recognize this process. As you can see, these are his anatomical studies and his pictures, and he even had a stamp after him in recognition of all his work. Charcot's original recommended treatment was bed rest, a firm bandage support, physical rehabilitation, and attempted offload. Not much has changed since 1881 in terms of standards of care for treatment of Charcot arthropathy in the acute phases. And even at that time, there was high failure rates in order preventing the rocker bottom deformity of the feet. Charcot suggested that fractures of bones and diseases of joints resulted from lesions of the spinal cord, specifically posterior sclerosis of the spinal cord. Because of this, there's increased blood flow to the bones, creating a washout effect and weakening of the bones. This has been dubbed the neurovascular theory, or otherwise known as the French theory of Charcot arthropathy. At the same time, the Germans encountered similar affections of joints, specifically Volkmann and Virchow. Their theory stated that minor trauma on an insensate foot and repetitive trauma created joint subluxation and subsequent fractures and dislocations. Charcot, on the other hand, argued against this process, stating that he had noticed some of these joint destructions without any significant trauma. Today, we have this unified theory, which states it's a French plus German theory. There's three forms of neuropathy. Essentially, you have autonomic neuropathy. That creates hyperemia, which is a washout of the bones, similar to what Charcot previously indicated. There's motor weakness, especially in the intrinsic smaller muscles that stabilize joints in the foot. This creates joint instability and subsequent laxity, subluxation, and oftentimes fractures and dislocations. This is all preceded by this sensory deficit that prevents the ability to recognize your position in space, otherwise known as loss of proprioception. In the last decade, with advanced techniques, we now recognize that there's an imbalance between pro and anti-inflammatory signals in the body. This in turn activates the bone-resorbing osteoclast, leading to a softer and weaker bone. There are multiple growth factors that are involved in this process, and in this picture, we can represent the mechanism of activation, mainly known as the rankle system. In this process, macrophages and other progenitor cells are activated into osteoclasts, and even mature osteoclasts are reactivated. In this process, the osteoclast will go in and resorb some of the bone, making it significantly weaker. So moving on to the more clinical aspect of Charcot foot, who is at risk for developing a Charcot foot? Oftentimes we think that it is exclusive to diabetics, but the reality is anything that causes neuropathy can predispose people to developing a Charcot foot. However, diabetes and alcoholism remain the most commonly reported processes that create a Charcot foot. When thinking about diabetics, how many of them actually develop neuropathy? It's estimated that 25 to 35% of patients with diabetes will develop some degree of neuropathy. And from those, approximately 0.1 to 5% will develop a Charcot foot. But really the true incidence is still unknown, secondary to misdiagnosis and delayed diagnosis. The clinical presentation of the Charcot foot can be somewhat confusing because it does resemble many other diseases. And typically, on average, it takes 29 weeks before a Charcot foot is actually diagnosed. The acute presentation is typically a red, hot, and swollen foot. These are nonspecific findings present in other disease processes, such as infection and gout. Some of the key features, however, is the absence of pain, whereas infection, gout, and blood clots are typically fairly painful. When measuring the foot temperature, as seen in the picture above, classically, there's a 3-degree difference between the affected foot and the unaffected. So what we often see is the patient will present to its primary care physician or the emergency room with a swollen foot. Typically, they're giving antibiotics or treated for gout or evaluated for a blood clot, all very important aspects of differential diagnosis. However, the patient continues to walk on the foot, further deformity and tissue damage occurs, which often leads to foot ulceration, subsequent bone infection, and oftentimes a partial or minor amputation or major amputation in many cases. This is an example of such a case with a patient with a navicular fracture that was missed on initial radiographs. The patient continued to walk with a progressive further collapse of the navicular. Without proper offloading and correct diagnosis, the talus continued to dislocate plantarly, creating a wound on the plantar aspect of the foot. Subsequently, there was complete collapse of the ankle, subtalar, and midfoot joints, creating an ulceration with gas gangrene, requiring a major amputation of this limb. The diagnosis of Charcot foot is primarily clinical. Special attention on a patient with diabetes, neuropathy, or any patients with neuropathy is any type of history of trauma. It could be minor or major, neuropathy, edema, and erythema, or a combination of the above. A high clinical suspicion is needed in order for us to recognize the Charcot foot. There are anatomical and physiological classifications that help us recognize the location and stages of the disease process. This is one of several anatomical classifications, the Frickberg anatomical classification, essentially showing that Charcot arthropathy can occur at any joints in the foot, including the forefoot metatarsophalangeal joints, tarsal-metatarsal joint, midfoot, calcaneus, and the ankle joint. Brodsky also has his own classification system, very similar to Frickberg's, again showing the different areas of Charcot afflictions, and again subcategories depending on the area. The most common areas that Charcot affects is the tarsal-metatarsal joint complex and the midfoot. Those two areas make up about 80% of the anatomical locations involved in Charcot arthropathy. Eichenholz described the clinical and radiographic findings according to stages of Charcot arthropathy. Later on, there was the added stage, which includes a stage 0, and that is before any radiographic indications of Charcot arthropathy exist. The added stage, the stage 0 Charcot foot, is an important stage of recognition. This is where the patient typically comes in with a red, hot, and swollen foot with minimal to no deformity and minimal to no pain with normal radiographs. The physician has to have a high index of suspicion and rule out the Charcot arthropathy foot. Failure to recognize the stage 0 will move on to further stages, as this is a progressive joint dislocation disease with continued ambulation and the ground reactive forces. In stage 1, fragmentation occurs where there's capsular distension and joint dislocation. As the patient progresses through the stages, in stage 2 there's a coalescence stage where the bone fragments coalesce or gel together. There's a decrease in edema and return of normal temperature to the foot. and absorption of some of the fine bone debris. And lastly, stage 3, which is the reconstruction stage, the consolidation and bone remodeling. Clinically, there is no edema and the temperature is equivalent to the contralateral foot. Some stages of inflammation all the way to the remodeling. The importance is the offloading in these patients. Failure to recognize this can continue to cause devastating effects and severe deformity, including a rocker bottom deformity. It is important to note that at any point, even after remodeling, there is a 23% chance of recurrence of a Charcot foot. And that's something to keep in mind and is very important for offloading and future bracing and monitoring of these patients. In terms of imaging, fetal radiographs often are normal in the early stages, but those are important to serially monitor. MRI is essentially the earliest portion of advanced imaging for early diagnosis and monitoring of the disease activity. In the acute process, there's bone marrow edema, soft tissue edema, and subcondylar fractures. And in the chronic MRI, there is subcondylar cystic changes, joint destruction, some form of joint effusion, and bony perforation. The steps of treatment include 1, obtaining an accurate history and clinical exam, ruling out the other differential diagnoses, conventional fetal radiographs, MRIs when needed, and protective immobilization, approximately 10 to 16 weeks and even up to 20 weeks, depending on the progress of the patient. In terms of offloading devices, total contact casting is the current standard of care, but other immobilization devices can be utilized, such as cam walkers. Once the process of Charcot arthropathy comes to stage 3 and local edema and temperature has returned to normal, transitioning into a Crow device is very important. And this can be utilized for approximately up to 1 year, or until the foot is completely stable. Further progression from the Crow device into an ankle foot orthosis and customized shoes with inserts is very critical for these patients, and compliance with these devices is very important. 60% of the time, surgical intervention is not required. The indications and timing of surgery are associated with significant joint dislocations, instability, unbraceable deformity, deformity with impending ulcers, or active infection. Surgical intervention can be as simple as an exostectomy or shaving down bony prominences, all the way to major reconstructive surgery with the utilization of external fixation. Surgery is very risky with 50% complication rate and oftentimes 50% amputation rate in these patients. The surgeon needs to be familiar with various surgical techniques, including internal and external fixation, and oftentimes multiple surgeries are required in utilization of multiple techniques to obtain a plantar grade foot. And the goal of surgery is to eradicate infection, resolve ulceration, and obtain a braceable plantar grade foot. Current use of sensor technology is helping us combat the severe deformity of Charcot arthropathy. These include specially made socks with sensors inside them that detect changes in temperature in the foot. The patient and the physician are alerted that there are changes in the temperature, and offloading is instituted at an early stage before deformity or ulcerations occur. Smart inserts, also with sensors that allow interactive mode, where the patient gets notified via phone message that there is high pressure or high temperature in the foot that requires offloading or evaluation by the physician. In summary, early recognition is the key to preventing ulcerations and amputations. Having a high index of suspicion for the Charcot foot is critical, and intervention at a very early stage is the most important part of preventing ulcerations and amputations. Charcot arthropathy of the foot and ankle and lower extremity continues to be a very difficult problem to treat. We are still conducting more research in order for us to understand better ways of treating this deformity and preventing this deformity. And again, early recognition is the key to success. And being educated in regards to patients at risk is very important. Again, thank you so much for inviting me to your wonderful meeting.